Ladies and gentlemen, first of all, on behalf of the Colombo North Center for Liver Disease, I would like to welcome you all for this lecture on basic interpretation of common liver function abnormalities today. And I would like to thank you all again for joining, because it's a fascinating topic and you will never regret learning it, whether for exam purposes or for clinical purposes. And I'm going to discuss 12 interesting patients today. And first 8 would be fairly straightforward and easy. And after that, I will discuss 4 more rather difficult cases towards the end. Okay, so what's a liver profile? Although we call it liver function tests at times, it usually measures liver dysfunction. Although in disease like albumin measures liver function, most of the time when they're elevated, it measures liver dysfunction. So I would, I like liver panel. I think it's a more preferred term for this liver profile or liver function test. So it consists of ALT or SGPT, AST or SGOT, then serum albumin, globulin, then serum bilirubin, then alkaline phosphatase, and gamma glutamyl transferase. To start with, I would like you to introduce this liver histology slide. You know, this basic liver lobule consists of the central vein, and these are the hepatocytes. And in one side, they are lined by the sinusoid, and on the other hand, they are lined by the bile canaliculi here, which then joins the small bile ducts, the large bile ducts, and the hepatic. So when there is some kind of damage to these hepatocytes, the enzymes or whatever the enzymes which are inside, whether there is AST or LTO, alkaline phosphatase or gamma GT, are released into the bloodstream. This is a hepatocyte, and you can see this is the sinusoidal side, and this is the biliary canalicular side. And the hepatocyte contains various enzymes like ALT, alanine transaminase, or SGPT, then AST. And ALT is mainly cytosolic, that's in the cytoplasm, and AST is mainly in the mitochondria. And this is important clinically because illnesses that will damage mitochondria will release more AST into the circulation. Although gamma GT and alkaline phosphatase are found in the hepatocyte, most of them are concentrated in the biliary canaliculi. Because of that, when there is an insult into the biliary system, like a block or in a block, you get back pressure leading to damage. Then if there is an infection like cholangitis or any autoimmune process or inflammation, then we will see more alkaline phosphatase and gamma GT released into the circulation. Say, before going into details, I would like to introduce into some of the basic principles like the laboratory errors, then units, then upper limits of normal, and others, right? So if you are doing a liver profile, make sure that you do it from a reliable lab, because most of the time, if you do it from a lab that is not accredited, you'll see fair amount of lab errors leading to wrong diagnosis. Then units, you have to be very careful with the units, whether they are in milligram percent or whether they are in micromoles before taking clinical decisions, because again, errors due to various units are commonly seen. Then again, upper limit of normal, because different labs have different calibration systems, and sometimes the for alkaline phosphatase upper limit of normal is 340, and from other labs it is 113. So then if you measure, uh, uh, you will have wrong diagnosis if you are not careful with the upper limits of normal. Again, when you are interpreting these values, make sure that the patient is, whether patient is symptomatic or asymptomatic, because if you find gross abnormalities in a patient who is asymptomatic, again, you have to consider lab errors. So I told you that I'm going to discuss 12 patients today and start with this simple looking liver profile. Is a 28-year-old man with fairly high BMI with a family history of diabetes, and he is asymptomatic, and he admits taking alcohol at functions and found to have this liver profile in a medical examination for insurance purposes. So if you go through this, first, as I told you before, you have to make sure that it's from a reputed lab. Then look at the upper limits of normal. See the gross abnormalities are seen in the alanine transaminase or SGPT and gamma glutamyl transferase. And here, alanine transaminase is elevated and gamma GT is elevated about 3 times, and alanine transaminase is elevated above the normal limit. This is a common abnormality that you can see in these age group in patients who have these metabolic risk factors. So this could well be something like fatty liver leading to some degree of non-alcoholic steatohepatitis, or although he takes alcohol only occasionally, as revealed by the gamma GT, he may be taking slightly more than what he reveals, and he may be having alcohol-induced fatty liver or early alcoholic hepatitis for that matter, or alcohol causing induction of liver enzymes, mainly gamma GT. So this could be a mixture of alcohol plus fatty liver, because he has higher BMI and he has a family history of diabetes. So chances are that he's going to get diabetes in the future. So ALT, if you discuss alanine transaminase or SGPT, it's more liver specific, and it's, as I told you before, it's encountered in the cytosol, raising damage and cell death. So as I told you, it's not a function of, it's not a measurement of the liver function. It's a marker of cell death or cell damage. So ALT has a longer TR for about 72 hours, and this is important clinically. And the normal value we see in healthy people are due to programmed cell death or apoptosis. So if we have higher ALT level, that what it means is that we have higher hepatocyte death rate. So it's not good news. So usually livers, our liver is, if our liver is normal, we should have liver enzymes within normal limits. And also the current accepted normal limits are much lower. See this, it's 34 males and 19 for females. Although most of our labs nowadays say that 40 is the upper limit of normal. So 40 is twice as high as normal for a female. So if we take the lab report as correct, we may be forgetting quite a few females who have elevated liver enzymes. So AST or SGOT is both cytosolic and mitochondrial, and it has a shorter half-life of about 24 hours. And AST is affected by muscle disease and hemolysis. So if there is elevation of SGOT or AST or aspartate transaminase, you have to make sure that it's not coming from somewhere else other than the liver. So I will discuss the second patient now. A 28-year-old man was detected to have abnormal LFTs at a medical test again. So he is also asymptomatic and he visits the gymnasium regularly. This is his liver profile. I will give you a couple of minutes or at least 1 minute to gather your thoughts and you can answer with me. By the way, his bilirubin was also elevated at 2.6. I can't find it here, but his bilirubin was also elevated. So you all can go through this. I will give you 1 minute to gather your thoughts, and then we can if there are any issues, you can put it to the chat box. Then I will discuss the question. Okay, so basically his transaminases are elevated and bilirubin is elevated. Transaminases, mainly AST, is elevated. See, this is 21st of August. Then he came to me about 2-3 weeks later, and this is his liver profile now. It's totally normal except for bilirubin. Okay, so what could this be? By the way, I'm going to do this as another case later, but bilirubin was mainly indirect and it is insignificant. So what could have been the cause for this elevation? One thing is a lab error. So if this lab is not certified, I do not know whether it was a lab error, but if not, the other possible explanation is some kind of muscle damage due to heavy exercises. So we see this type of picture in patients who undergo heavy exercises due to muscle damage. And unfortunately, if we had done a CPK at this time, we could have differentiated. But when he presented to me nearly 1 month later, there was no CPK elevation. So possible causes are either a lab error or rhabdomyolysis or muscle damage due to heavy either weightlifting or heavy exercises. So causes of AST elevation due to muscle illnesses, extreme exercise. We see this in dragging, army training, and during accidents, struggles, assaults, seizures, myopathies, and some drugs like antipsychotics leading to neuroleptic malignant syndrome. Then in myocardial infarction, we used to test AST as a marker of myocardial infarction when we are medical students. So now we do troponin I or troponin T or whatever, but many years ago, many decades ago, it was SGOT, which was CPK will differentiate muscle AST from liver AST. So to discuss more about serum transaminases, as I told you before, SGPT is liver specific. SGOT is also found in muscle and red blood cells, and it was used to diagnose myocardial infarction. And very high levels are found in viral hepatitis, like 5,000, 6,000. And the degree of damage may not correlate with the severity of liver damage. So ALT of 5,000 in a viral hepatitis patient may not be as serious as ALT of 500 in a drug-induced liver disease. So this patient may survive, and drug-induced liver disease patient with a ALT of 500 could well be dead if not looked after. So the degree of damage do not correlate directly with the severity of the liver damage. And the transaminases are not high in obstruction. They may be even normal in cirrhosis. So a medical student says when you ask about investigating a patient with cirrhosis, if you say transaminases, you will not get marks because they are not significantly elevated in cirrhosis. And the AST-ALT ratio is very useful in differentiating various liver diseases. That's why we are doing AST. Otherwise, what's the purpose of doing AST when ALT is very liver specific? The whole purpose of doing AST is to differentiate various liver illnesses by measuring this AST to ALT ratio. So if AST is more than ALT, it directs you on different pathways of diagnosis. So this was described 60 years ago. This paper still valid with the addition of dengue. If you add dengue to this publication, and that publication is still valid now. So what are the illnesses with different AST to ALT ratio? Usually in health, in normal people, ALT is more than AST. It is due to a very rapid clearing of AST because it has half-life of 24 hours, and whatever are produced due to apoptosis is washed off immediately. So usually in health, ALT is more than AST. In hepatitis, when the transaminases are raised, ALT is more than AST in NASH, viral hepatitis, and autoimmune hepatitis. At the same time, when there is very severe damage in viral hepatitis and autoimmune hepatitis, when there is extremely high production rates or severe hepatitis, AST may be more than ALT because there's no time for it to be washed off, and that carries a poor prognosis. If in viral hepatitis, AST is more than ALT, it carries a poor prognosis. And AST is more than ALT in alcoholic hepatitis, cirrhosis, ischemic hepatitis, that's shock liver, and dengue fever. And here the AST elevation should be due to liver disease, and you have to exclude hemolysis or abnormalities or AST coming from muscles before taking clinical decisions. So why AST high? I will take an example, alcoholic hepatitis. Why AST high? Due to many reasons. One is pyridoxal phosphate or vitamin B6 deficiency, which leads to low ALT levels because this vitamin is needed for the hepatocyte to release ALT. So produce and release it. So ALT levels are low. Then when there's mitochondrial damage, I told you this earlier, when there's various diseases give rise to mitochondrial damage like alcohol, some drugs, some viruses like atypical viruses, when they destroy the mitochondria, and then AST is high, and the reduced clearance due to reduced blood flow due to fibrosis. When advanced cirrhosis, fibrosis cirrhosis, liver blood flow is compromised due to fibrosis. Then the wash-off is impeded and AST starts going up compared to AL. Then because we see most of the time these illnesses, fatty liver and NASH, I would like to tell you a few things about diagnosing NAFLD with a liver profile. Usually in NASH, ALT is more than AST, and usually it does not go up beyond 5 times the upper limit of normal. Usually in NAFLD, it won't go beyond 200. And here in NAFLD, gamma GT may be raised, but rest of the liver panel is usually normal. Bilirubin, alkaline phosphatase, albumin, globulin, those are going to be normal. So usually ALT is raised and gamma GT may be raised. And in our setup, in middle age, 30% of our adults will have fatty liver, and in the elderly, it is raised to about increased to about 60% of the population. And 75% of these patients will have elevated liver enzymes. And this degree of elevation is not correlated to the progression of disease. So it's not that a patient with 200 is going to develop cirrhosis quickly or more often. So there's nothing like that. And then again, degree of fatty infiltration. A lot of people come and ask you, there's grade 1 fatty liver, grade 2 fatty liver, grade 3 fatty liver. When will I get grade 4 fatty liver? So there's no correlation with the progression of the illness with the degree of fat infiltration. So detect progression, we need the FIB4 index. I will let you know. And NAFL can progress with normal liver enzymes. It doesn't mean that if you have normal liver function test that you are not going to progress into cirrhosis. You can progress to cirrhosis if you have fatty liver even with normal liver function test. But if you have this app, this is free online, this app. If you can calculate this FIB4 score, it consists of the age, the AST, the ALT, the platelets, then that will tell you something more about the risk of progressing into fibrosis. For as of now, all patients diagnosed with NASH or NAFL should have this score calculated every 1 or 2 years. In diabetics, every year, and if you don't have diabetes, maybe every 2 years, to see whether there is risk of progression to cirrhosis or fibrosis or cirrhosis, and then take necessary action to prevent it. So then patient 3, a 50-year-old lady has a cardiac arrest following an invasive procedure following a concealed hemorrhage. So we had a radiological procedure, and there was bleeding inside, and it was not detected early, and he had a cardiac arrest, and this is his liver profile. She was resuscitated, and this is her liver profile 2 days later. So I'll give 1 minute for you to go through this. So what are the striking abnormalities here? Very high transaminases. AST 6,700, ALT 5,000, AST more than ALT significantly, and albumin is normal, gamma GT normal, bilirubin elevated. So this is what's called a ischemic hepatitis or hypoxic hepatitis or shock liver. So this is not good news, especially in middle and elderly people who have already compromised liver function with fatty livers, early cirrhosis. So this patient did not survive this liver assault, and she succumbed to illness a few days later. So this is shock liver, and one of the main reasons for grossly elevated transaminases along with viral hepatitis and toxic necrosis like paracetamol poisoning. We commonly see this in dengue hemorrhagic fever leading to shock. So massive elevations, I told you, viral hepatitis, ischemic necrosis, cardiac arrest, dengue shock syndrome, toxics like paracetamol toxicity. So these are the reasons for massive elevation of liver functions, and these type of elevations we do not see in autoimmune hepatitis, NASH, alcoholic hepatitis, and even other illnesses like hemochromatosis, Wilson's, and so on. So fourth patient I am going to discuss today, a 36-year-old patient with alcohol-induced cirrhosis presented with icterus and bilateral ankle edema. He had restarted drinking 2 months ago. Alcoholic cirrhosis patient stopped for some time and restarted drinking, presented with jaundice and ankle edema. This is his liver profile. You can go through this. I'll give you 1 minute, and just to see what are the striking abnormalities in this liver profile. Alcoholic, had cirrhosis, stopped drinking, was better, then restarted drinking and presented with jaundice and bilateral ankle edema with this liver profile. So there are quite a few striking abnormalities in this liver profile, characteristic of a cirrhotic. Firstly, low albumin, then elevation of globulin, reversal of the albumin globulin ratio. All are features of advanced cirrhosis. Then there is elevation of bilirubin, either it is due to cholestasis or liver failure. Then there is reversal of AST-ALT ratio. It's a feature of cirrhosis. Then there is very marginal elevation of alkaline phosphate just above the upper limit, but gamma GT is about 8 times elevated. So this is due to probably enzyme induction. There may be a bit of cholestasis also, but contributed by enzyme induction due to alcohol. This is probably some degree of alcoholic hepatitis on top of cirrhosis, leading to this acute decompensation. This is decompensated cirrhosis due to alcohol. There may be a little bit of acute on chronic liver failure as well, but for most of you, it is decompensated cirrhosis, and this gamma GT could well be due to recent alcohol intake. Okay, so causes for low albumin cirrhosis, obviously low albumin with reversal of albumin globulin ratio in cirrhosis. Then there are other causes for low albumin, like nephrotic syndrome, when you lose albumin in your kidneys, then malabsorption, malnutrition, then protein losing enteropathies like various illnesses like celiac disease, Crohn's disease, lymphomas, where you lose proteins from the gut, and also malabsorption. So if you don't absorb proteins, then your albumin will be low. Then severe sepsis is one of the very well-known cause for low albumin. So there aren't many for low albumins, are very few, right? So maybe 4 well-known causes for low albumin. So fifth patient who had a liver transplant 2 years ago presented with a urinary tract infection. He was otherwise healthy. So this is his liver profile. I will give you 30 seconds to go through this. It's very easy. Only striking abnormality is raised globulin. So this liver function, this liver panel looks very normal except for raised globulin, and his liver he responded very well to urinary antibiotics and recovered fully. And so elevated globulins, as I told you, it could be cirrhosis, infections, inflammatory conditions like autoimmune hepatitis, obviously the liver condition. In autoimmune hepatitis, you see very high globulins. Other inflammatory conditions like rheumatoid arthritis, SLE, any chronic infections like TB, sometimes in acute infections, multiple myeloma. So if you see very high globulins in the liver profile, it could tell you a different story. The rest of the liver profile is normal. It could well be multiple myeloma in an elderly patient, or it could well be if the liver functions also abnormal, but the liver there are no features of cirrhosis. It could well be autoimmune hepatitis. You should be alert to these signals to make a diagnosis, although it may not be directly related to the liver. But when you do the liver profile, if you see these abnormalities which are not directly related to the liver, make sure you do the correct investigation to diagnose, because you don't get very high globulins for no reason. There should be some underlying cause for it. So I have discussed ALT, I have discussed AST, I have discussed AST-ALT reversal, then I have discussed grossly elevated transaminases, then I have discussed causes for low albumin, I have discussed causes for albumin globulin ratio reversal, then I have discussed causes for elevated globulin. For all of them, you have liver related causes and liver unrelated systemic causes. Next patient is a 40-year-old female presenting with yellowish discoloration of the eyes and pruritus for 2 weeks after starting carbimazole for thyrotoxicosis. Carbimazole for thyrotoxicosis, a very well-known toxic drug for them. liver, but a very useful drug in thyrotoxicosis. This is the liver profile of that 40-year-old female who presented with jaundice and pruritus 2 weeks after taking carbimazole. So I'll give you 1 minute for you to go through this. Okay, so what are the striking abnormalities? This albumin is nearly normal. Globulin is slightly elevated. This is the most striking abnormality. Bilirubin 8.6. AST normal, ALT is slightly elevated, maybe 1.5 times. Alkaline phosphatase 2 times. Gamma GT 2 times upper limit. So this is probably a drug-induced cholestasis. Drug-induced cholestasis. It's a kind of drug-induced liver disease or drug-induced hepatitis or drug-induced liver injury. The current nomenclature is DILI. I will come back to it. So high bilirubin elevation could be conjugated bilirubin or direct bilirubin, or unconjugated bilirubin or indirect bilirubin. And drug-induced liver injury can be hepatocellular, or when there is greatly elevated transaminases, or cholestatic, like this patient, when the bilirubin is greatly elevated, or mixed DILI, where when there is hepatocellular or and cholestatic picture together. So I'm not going to tell you how to differentiate between hepatocellular, mixed, and cholestatic DILI. There are various ways and various laws of diagnosing individual types of DILI. But what I want you to know is that due to drug-induced liver disease, some people will have elevated transaminases, some people will have cholestatic features like elevated bilirubin, alkaline phosphatase, and gamma GT, and some patients can have a mixed picture. This patient, fortunately, bilirubin came down to normal over 3 months. It takes time. So about 20% of these patients die, so need a liver transplant. So so if you are using a drug, you have to make sure that you are using that for a very good indication, because even a tablet of diclofenac sodium can kill you. A tablet of maybe coamoxiclav can kill you. So don't use drugs without a very good reason. So patient number 7, a 30-year-old asymptomatic man was investigated for raised bilirubin. His other liver functions, including alkaline phosphatase, gamma GT, were normal. Liver ultrasonography was normal. His reticulocyte count was also normal. So this patient, in fact, we discussed earlier. So this was the cause for his raised bilirubin. Bilirubin was 2, and when you do the fractionations, direct was 1, indirect bilirubin 1.6, and total was 2.6. This is very common. This is most likely to be Gilbert syndrome. You have to make sure that there is no hemolysis. You can exclude hemolysis by doing a retic count, hemoglobin, and a blood picture. If there is no if there's no hemolysis, you can safely diagnose Gilbert syndrome in the presence of normal liver panel. Rest of the liver panel is normal. So no gamma GT, alkaline phosphatase is normal. And if it is normal, this indirect hyperbilirubinemia need no further investigations. So increase unconjugated to indirect bilirubin inside the hemolysis, basically your inherited disorders of metabolism like Gilbert syndrome. So I would like to tell you a bit more about Gilbert syndrome, because it's so common. Roughly about 10% of population will have it. They are usually asymptomatic, detected during illnesses like viral fevers or fasting, because then when there's fasting with fever, you don't eat, then bilirubin goes up, then they become icteric, and then when you do a liver profile, bilirubin is raised. If you don't do fractions, then you misdiagnosis it as some kind of a hepatitis. So here the bilirubin never reaches extremely high levels. It won't go beyond 4, 5, and they have normal life expectancy. So if you diagnose Gilbert's uh, uh, confidently, then you can exclude a lot of unnecessary investigations. We have seen patients undergoing liver biopsies to detect Gilbert syndrome, which is totally unnecessary. So this if you diagnose Gilbert's, you avoid a lot of unnecessary investigations. So at the same time, sometimes at the same time you can have benign causes for conjugated bilirubin also, direct bilirubin. So usually we detect conjugated bilirubin or direct bilirubin in extrahepatic obstructions like stones or cholangiocarcinoma, or intrahepatic cholestasis like drug-induced cholestasis, or rarely you can have integrated disorders of metabolism causing benign Dewey-Johnson syndrome. So this is not as common as Gilbert syndrome. Once in a while you see this. To tell you, I know 2 pediatricians with Dewey-Johnson syndrome. So it's not can't be uncommon, right? So get elevated direct bilirubin and presents with they usually present with icterus during pregnancy. So in pregnancy, it's bit troublesome to diagnose it because alkaline phosphatase is usually normal if you are not pregnant, but in pregnancy, alkaline phosphatase also go up. Then there's only gamma GT for differentiation. So when they present in pregnancy, it's difficult to diagnose, and you have to do at least ultrasound scan to make sure there's no obstruction in the biliary system. With after pregnancy, bilirubin comes back to normal. So patient 8, a 39-year-old female presented with generalized ill health. She was detected to have hepatosplenomegaly. She was obese. She had ESR, high ESR, severe untreated hypothyroidism, diabetes, and hypercholesterolemia. So she was living with all these for many, many years. One fine day she presented with generalized ill health. So this was her liver profile. I'll give you 1 minute for you to go through the abnormalities. Okay, so what are the striking abnormalities? Normal bilirubin, normal albumin, raised globulin, not very high. OTPT raised and reversed. Alkaline phosphatase 3 times upper limit normal. Gamma GT 6 times upper limit of normal. So static picture, but no elevation of bilirubin. So she was too complicated. She had diabetes, she had hypercholesterolemia, she is obese, she has hepatomegaly, she had hypothyroidism, PSH was over 100, untreated. So she had ESR of more than 100. So she was complicated. So no single disease could explain this. She could have had NASH with, we all know that you can have liver function abnormalities with hypothyroidism, hyperthyroidism, then obesity. So it could well be if the ESR is high, autoimmune hepatitis. So we did the liver biopsy. All other liver investigations like viral hepatitis screen, autoimmune screen, all were normal. And liver biopsy also showed only fatty liver or non-alcoholic steatohepatitis. So this lady has no diagnosis as of now. So we are treating the diabetes, we are treating the hypothyroidism, and we have advice on weight reduction, and we are waiting to see whether these liver functions improve with treatment. We really do not know the cause. So here the striking abnormalities are raised alkaline phosphatase, raised gamma GT, reversal of the ST-ALT ratio, and raised globulin. Right. Okay. So to to increase the gamma GT and alkaline phosphatase, you need some kind of uh, insult here in this area: bile duct, small bile duct, biliary canaliculi, and canalicular membrane of hepatocyte. Whether it is back pressure, whether it is infection like bacterial infection, cholangiopathy, drug-induced liver disease, primary sclerosing cholangitis. So there's some kind of assault here, but unfortunately in the liver biopsy, all the bile ducts and biliary canaliculi were normal. So we couldn't explain as to why there was elevated alkaline phosphatase and gamma GT in this patient. Right, okay, so high alkaline phosphatase and gamma GT, they are raised in biliary duct injury or obstruction. It could be either intrahepatic or extrahepatic. So example, intrahepatic injuries are drugs, primary biliary cirrhosis, primary sclerosing cholangitis, autoimmune overlap syndromes, then transplant rejection, then infiltrations like tuberculosis, sarcoidosis, lymphoma, extrahepatic causes like cholangiocarcinoma, gallstones, strictures, carcinoma head of the pancreas. So all these can elevate your gamma GT and alkaline phosphatase. And biliary damage, alkaline phosphatase takes time to go. So for example, in acute biliary colic, obstruction of the bile duct with the stone, you get the pain, you get AST/ALT rise, but ALP, alkaline phosphatase rise, takes few days. And difficult to differentiate between extrahepatic stone from intrahepatic, like a drug-induced cholestasis. So you just can't differentiate a stone or a cancer, bile duct cancer or cholangiocarcinoma from a drug-induced cholestasis just by doing the biochemistry. For that, imaging is mandatory, whether it's MRCP or whether it's ultrasound scan or CT scan. Imaging is mandatory to differentiate between extrahepatic obstruction and intrahepatic obstruction. So sometimes you see isolated elevation of alkaline phosphatase. Only alkaline phosphatase elevated, gamma GT normal. Then it's trouble. It's usually non-liver. Then what are the causes for non-liver elevation of alkaline phosphatase? Bone disease, Paget's disease, vitamin D deficiencies, bone secondaries, bone tumors, renal osteodystrophy. Then you get elevated bone disease. Then in childhood, pediatrician will know that alkaline phosphatase is always elevated during growth period. Then in pregnancy, it is due to alkaline phosphatase due to placental alkaline phosphatase. So alkaline phosphatase elevated in the absence of gamma GT, then it's very likely have another cause other than liver disease. So you can do isoenzymes, but it's very costly and it's not routinely available. So what we do is to do gamma GT if we suspect elevated alkaline phosphatase to make sure it is of liver origin. And alkaline phosphatase is considered low in Wilson's disease theoretically, but I don't know how important it's practically. So patient 9, a 70-year-old man has cirrhosis on ultrasonography. He had recent loss of weight and loss of appetite. This is his liver profile. So 70-year-old elderly man, not diagnosed cirrhotic, but went for a cirrhosis ultrasound scan because he had some weight loss and loss of appetite. This an ultrasound scan showed cirrhosis, but this is the liver profile. So go through this carefully, and I will give my thoughts after you go through it. Okay, the most striking abnormalities are low albumin, high globulin, reversal of the albumin-globulin ratio, very likely to be cirrhosis. Reversal of the AST/ALT ratio, very likely to be cirrhosis. Then grossly elevated alkaline phosphatase. This is about 4 times the upper limit of normal. Grossly elevated gamma GT, this is about 8 times the upper limit of normal. So 8 times gamma GT, 4 times alkaline phosphatase. So bilirubin high. So this is characteristic of a hepatocellular carcinoma. So we didn't have a CT scan or alpha fetoprotein to confirm. So this patient needs a contrast enhanced CT scan. Then you will ask me why the hepatoma was not seen in the ultrasound scan. Most likely it could be a diffuse hepatoma. So some hepatomas are not detectable on ultrasound scan. So still I do not know whether it's hepatoma or not, but this picture is recent loss of weight, loss of appetite, grossly elevated alkaline phosphatase, no bile duct dilatation on ultrasound scan. So this could well be a hepatocellular carcinoma. Okay, patient 10, 45-year-old obese lady underwent a medical checkup. She is on treatment for ischemic heart disease. This is his liver profile and some other investigations. So just one abnormality, raised gamma GT. So what do you think the cause for raised gamma GT? Isolation, elevation of gamma GT. We quite often see uh, isolated elevation of gamma GT. I'm sure most of you know what it is. And I'm going to tell you a few extra things regarding gamma GT. Okay, so isolated elevation of gamma GT, drugs, alcohol. Obviously, we all know this, but you may not know that anti-epileptics, anti-TB drugs can give rise to elevated gamma GT due to enzyme induction. Then fatty liver. If you already don't have fatty liver, it predicts fatty liver because gamma GT is a marker of endothelial dysfunction and oxidative stress. Here, it could well be that if the patient is not drinking, this could well be oxidative stress because he is already having ischemic heart disease. So this could well be this cause, but it can be fatty liver, it can be drugs, it can be alcohol. So clinically, when do you use gamma GT in a clinical setting? For two reasons. One is to follow up alcohol abstinence. So we all use it in patients who abstain from alcohol to see whether they are abstaining and to confirm the origin of alkaline phosphatase. The alkaline phosphatase is elevated to check whether it is coming from the hepatobiliary tree. You do gamma GT. So those are the two main clinical indications for requesting gamma GT. But isolated elevation can be due to alcohol, anti-epileptic drugs, then fatty liver, NASH, then it's just a marker of endothelial dysfunction as well. Patient 11, a 32-year-old man was referred by a neurologist really for postgraduates. 32-year-old man was referred by a neurologist for evaluation of LFT abnormalities. He has progressive neurological deterioration with predominant motor weakness with extrapyramidal symptoms. His memory is failing and he has had recent features. So a real unfortunate 32-year-old was deteriorating rapidly over a few years. So he can walk properly, can't remember, he's having fits, he's weak, has extrapyramidal features, some cerebellar features as well. So this was his liver profile. In fact, this was not his true liver profile. This was similar to the liver profile he had. So abnormalities are AST elevated, ALT elevated, but not a lot. So the neurologist wanted me to make sure that this is not Wilson's disease. To make sure that this is not Wilson's disease, but this is not like Wilson's. So if it is Wilson's, neurological, we should see cave rings by now. Liver was ultrasonically normal. Serum cerebroplasmin was normal. Viral screen and autoimmune screen normal. But his CPK was 9,000. This is the catch. So CPK rise. He had this recent seizure, or whether it's a mitochondrial myopathy. So it fits into mitochondrial myopathy. So we are waiting for a repeat CPK see just elevated CPK was due to the recent seizure. So I just did the CPK because AST was higher than ALT. That's why I said how important this knowledge for a doctor, especially for a physician, to differentiate various illnesses in clinical practice. You will never regret mastering, learning the liver profile. Is going to be useful for rest of your lives as a clinician anywhere in the world. Okay, the last patient, a 60-year-old, was referred for transplant assessment with high MELD. You know the MELD score. He was clinically well. So he was referred for transplant, but see the liver profile. So what are the striking abnormalities here? One minute. So he's a patient with cirrhosis. Obviously, you expect the AST-ALT ratio to be reversed, slightly high gamma GT. Albumin normal, globulin not raised. So this is good synthetic function. So there is no decompensation here. So patient is a well compensated cirrhosis, because if a patient can produce albumin and albumin is normal, he's not going to decompensate. So I'm sure if you do the INR, it should be normal. That's synthetic function, clotting factor synthesis. But here the bilirubin is elevated but indirect. So this is probably a cirrhosis, well compensated cirrhosis patient with Gilbert syndrome. So if you calculate the MELD, see the MELD calculation. This again, like the FIB4 score, free up online. You need INR, bilirubin, and creatinine. Okay, that's all. And you need to say whether you is dialyzed or not. That's all. Then you calculate. So what happens is that when you calculate the MELD with high bilirubin due to Gilbert's or any other reason, hemolysis or thalassemia patient, then you get an inappropriate value. So that's why when you are calculating the MELD for transplant, you make sure your investigations are from a reputed lab, not from labs all over the countryside, reputed lab. And also when you are inserting the bilirubin, make sure that you are not including falsely high levels due to either hemolysis or Gilbert's or Dubinjon's or whatever. Otherwise, so this patient is not in the transplant is not indicated in this patient as yet. He may need the transplant in 2-3 years time, not today. Okay, before finishing, just two markers, two liver function tests. INR, it's a marker of current synthetic function. It's a very good marker of current synthetic function and useful diagnosis in liver failure, both acute liver failure, and it is incorporated into the MELD score. But again, reliability is a problem. Make sure that you do it from a reputed lab. And lactate levels, again, serum lactate levels is a good marker of current liver function and liver perfusion. If the liver is being perfused well, and lactate, you all know that it's a product of anaerobic metabolism, and it's a marker of tissue ischemia. It raised in all forms of shock, whether it is septic shock or dengue shock or cardiac arrest, it goes up. And the reason for to be a very good marker of liver function is that lactate is predominantly excreted by the liver. If the liver is functioning, your lactate levels will not go up. So if the lactate levels are rising, either liver is not perfused, like in shock, or liver is not functioning, like in liver failure. So it's a very useful marker in ICU setting. Probably one of the best markers of acute liver function. It's valuable in septic shock. This is incorporated into various scores to predict survival in septic shock, and it's of absolute value in liver transplantation to check whether new liver is functioning after transplantation. It gives results within first 15 to 30 minutes, I think. It will give you results. And also in dengue shock syndrome, if lactate is high in dengue shock, prognosis is poor. To summarize, ladies and gentlemen, all elevation of liver function should be carefully analyzed. No doubt about it. You should go through it carefully and make sure that you analyze it and tell whether it is abnormal or normal. AST-ALT ratio is of value in differentiating liver illness. So why do we do AST-ALT when ALT is liver specific? It's because when you do AST to ALT ratio, you can diagnose various, so it's very valuable in our setting, the poor third world country. Persistent and asymptomatic elevations are more significant because some of these, even if you get some viral infection, it can go up, but it will not persist. So if the liver enzymes are persistently high in a symptomatic patient, it needs attention because sometimes liver function abnormalities are self-limiting. In asymptomatic, and you can recheck in maybe 2-3 weeks, and if they are normal, you can leave the patient alone. Be aware of normal values because now AST-ALT values are the accepted normal values are different. It's 30 for males, 19 for females. Be aware of common benign or relatively benign abnormalities. So Gilbert syndrome common, NAFL common. So Gilbert syndrome and NAFL can coexist, and the liver panel or the liver function test will be very ominous looking. So a GP will refer the patient to a consultant, see elevated bilirubin, elevated AST, and please have a look. So, but if you carefully analyze, even at a general practitioner level, you should be able to diagnose Gilbert syndrome and NASH or fatty liver, which can be looked after even at that level. Laboratory issues are common, so make sure that you are doing these tests because they are very sensitive tests, and when you are using them in various apps and various scores to predict fibrosis, to take transplant decisions. So make sure that you do it from a reputed lab, and if you see abnormal values, and don't take it the face value, but make sure that it correlates well with the clinical situation and the clinical findings of the patient. And liver function abnormalities are encountered in many systemic pathologies. I told you, myositis, multiple myeloma, hemolysis, infections, chronic infections. So just because it's not liver, don't just ignore other results. And you suspect systemic illnesses, make sure you refer the patient to relevant specialist to make a diagnosis. Thank you very much for kind attention. Natasha?
Yes, sir. First of all, I'd like to thank Professor Dasanayake for this excellent lecture. So now it's time for questions from the audience. Before we go for questions, I'd also like to give a kind reminder for our audience to fill the feedback form, which I have uploaded. And also, many have been asking about the lecture slides. So we'll share the lecture slides in our Facebook page, and the recording will be shared in our YouTube channel early next week. And then I'll post the links to our Facebook page and the YouTube channel so our audience can um, get the lecture. So we have a lot of questions today. So I'll start. So we have a question on. So in case two, why is the bilirubin elevated in this patient?
Natasha, I explained it in that patient with suspected uh, mild degree of rhabdomyolysis who went to the gym and had raised AST more than ALT. His bilirubin elevation was due to Gilbert syndrome. That's why I said nowadays these illnesses are so common. Gilbert's is common, NASH is common. So we frequently see, say, if you see a patient with Wilson's, at the same time, NASH can coexist, and at the same time, Gilbert's can coexist. So it's not easy to explain the liver functions in that kind of a patient without investigating, right? So in this patient, the case number 2 is a young man, totally asymptomatic, just went to the gym. Next day, he went for a medical checkup for an insurance scheme. And then on that particular day, he had bilirubin rise and AST rise more than ALT. So AST ALT settled over next 2-3 weeks, but bilirubin remains high. Bilirubin rise was due to Gilbert's, and probably transaminase rise was due to extreme exercises. Does it explain your answer for the question, Natasha?
Yes, I think it's clear. So, and then
Okay.
we have another question on the same patient. So, this patient, the audience is asking, why is ALT also elevated?
ALT elevation, uh, ALT also seen encountered in the muscle. Although ALT is predominantly liver, ALT, some degree of ALT is also found in the muscle. So that's why there's more AST in the muscle, but little bit of ALT in the muscle. The other explanation is he may be having a bit of fatty liver also, right? So most of our people have background elevation of ALT due to some degree of fat liver. So I think it's ALT is from the muscle, because the follow-up liver profile ALT was normal. So very likely that whatever the low quantities of ALT found in the muscle raise the ALT as well. Okay.
And we have another question. When a patient with dengue hemorrhagic fever is found to have elevated AST and ALT above 1000,
Yeah.
how to decide whether it is due to dengue viral hepatitis or ischemic hepatitis?
Okay. So very difficult question. I need an hour to explain that. So in dengue, you can have viral type of hepatitis, like hepatitis A kind of hepatitis in the liver due to direct action of the dengue virus on the liver. Secondly, you can have autoimmune type, because all the immune complexes, cytokines, and they can go and uh, damage the liver. Then finally, you can have shock liver or ischemic type of hepatitis at the end stage. Then only few ways of differentiate. One is you will generally will see other features of shock, like you will not get dengue hepatitis without systemic shock. So if the patient has fluid leaking to the abdomen, low pulse pressure, tachycardia, that kind of uh, uh, other features of dengue shock, then it will be dengue shock causing the liver damage. And very important parameter is the degree of elevation of AST. This is generally correct. If the degree of elevation is 3 times more than AST elevation is 3 times more than ALT. Say if the ALT is 1000, AST is 3000, is generally shock liver. That kind of differentiation you do not see in viral type of hepatitis here. So I will give you an example that I saw just before going into shock. A patient had a ALT of 90 and an AST of 600. That's 6 times more. So degree of AST elevation compared to ALT, if it is more than 3, it tells you that it is ischemic necrosis and nothing else. Okay. Okay, so if there is other features of shock, other features of leaking, and if the degree of elevation is much higher, more than 3 times that of ALT, then it's more likely to be ischemic necrosis of the liver due to dengue shock. Okay.
And then we have a question on case 8. It was the lady who had high ESR and a complex medical history with high ALP, gamma GT, and a transaminases. So the question is, case 8, can't it be primary biliary cirrhosis?
Well, primary biliary cirrhosis should be able to diagnose on biopsy. So in this lady, there was absolutely no bile duct damage in the liver biopsy. It was just non-alcoholic steatohepatitis on the biopsy. So still, I do not know whether what was the reason for AST-ALT elevation. Gamma GT may be fatty liver, but then alkaline phosphatase could well be vitamin D deficiency. So just got the biopsy yesterday, so I will check for vitamin D deficiency to see whether this alkaline phosphatase has a different etiology to gamma GT, because gamma GT very well be due to fatty liver. So really do not know. No, there were no features of primary biliary cirrhosis at all in this lady. Okay, usually the primary biliary cirrhosis patients present with pruritus, generally older patients like 45, 50, he's 39, 40. So 45, 50, 55 is the presenting age for primary biliary cirrhosis. And usually they do present with pruritus. It's not the presenting picture for primary biliary cirrhosis. Okay.
And then we have a question about gamma GT. So is gamma GT, can gamma GT be used to prove acute intoxication, or can it be used to prove alcohol consumption?
So gamma GT is good for chronic alcohol abuse rather than in binge drinkers. Also, it can go up, but invariably high in people who drink regularly in the long term. It's good to detect alcoholism rather than binge drinkers. So chronic regular users is anywhere, but what is said is that it's invariably high in chronic heavy users. Okay.
And
That's due to enzyme induction. The mechanism is induction. Even if there is absolutely no liver disease in alcoholics, gamma GT is high. It's also high in patient taking phenytoin, carbamazepine, this anti-epileptic drug. Okay.
And so there's a question about the last case we discussed. Can it, the last one, is it can it be Gilbert's or Dubin Johnson?
Last case was the cirrhosis patient who well compensated. Albumin is normal, but AST-ALT ratio reverse. So fibrosis is there, significant. Albumin normal, that's good synthetic function. In this case, it was Gilbert's because indirect hyperbilirubinemia. Shall I go back to that slide? Indirect hyperbilirubinemia. See, direct bilirubin is 7, indirect bilirubin is 20. So this is indirect hyperbilirubinemia. So this is Gilbert syndrome.
And then there's a question on, can you elaborate on urinary bile acid in evaluation of liver dysfunction?
I couldn't hear Natasha.
Sir, Can you elaborate on urinary in evaluation of liver dysfunction?
Not clinically, usually currently we don't use urinary investigations much other than in exam settings. We ask medical students. So, for example, increase urobilin hepatitis. So those were used clinically when none of these investigations are present. So earlier, when there was no diagnosis, clinical diagnosis of hepatitis A, we just made hepatitis A diagnosis and transaminases and increased urobilin in urine. And in obstructive jaundice, you see bile in urine. So even now, medical students are not asked to do these testing even in the final exam. If you remember, during finals, we all went with checking urine for urobilin and bile, but now those tests are not just medical students are not asked to do those tests, so they are not very clinically significant now in the presence of but chemical pathologists may not agree with me, but clinically we hardly ever do these tests for our clinical diagnosis nowadays. I have never done, I've never used urine investigations for my clinical practice, maybe for the past 25 years.
And then there's a question on how do we differentiate drug-induced cholestasis from drug-induced hepatitis?
Okay, good question. So drug-induced, I told you the drug-induced, there are so many types of drug-induced disease. Hepatocellular. In hepatocellular disease, transaminases are elevated. Now, if you take this slide, here the transaminases are not elevated. So only the cholestasis picture is present. Bilirubin is high, alkaline phosphatase gamma acid. This is not significantly elevated. So this is drug-induced cholestasis or cholestatic delete. So delete is drug-induced liver disease. This is cholestatic delete. Say imagine if AST was 300, then ALT was 400, and these remain the same. Then it is hepatocellular delete. That is what called drug-induced hepatitis. So all these are types of drug-induced hepatitis. But when the transaminases are elevated, you call it hepatocellular type. And then when the alkaline phosphatase gamma GT and bilirubin are elevated, we call it cholestatic type. And in between, call is mixed type. So it can be either hepatocellular delete. This is what is commonly referred as drug-induced hepatitis. But in a way, all these are types of drug-induced hepatitis. Even the cholestatic disease is a drug-induced hepatitis. But the correct international term for this is DILI, drug-induced liver injury. You don't call it drug-induced hepatitis because sometimes you just see what's called bland cholestasis. You see the elevation of bilirubin only. So then people are reluctant to call it a hepatitis, but so the correct term is drug-induced liver injury. It can be hepatocellular, it can be mixed, or it can be cholestatic.
So another question on this case is in Graves' thyrotoxicosis, who's on carbimazole, how to differentiate disease-induced cholestasis from carbimazole-induced cholestasis? Now
here, usually thyrotoxicosis will not give rise to this much of cholestasis. Thyrotoxicosis can give rise to changes in the liver enzymes, transaminases, and maybe alkaline phosphatase gamma GT, but it will never give rise to this much of cholestasis. This patient is really jaundiced. 8 milligram per cent. Bilirubin is 8 milligram per cent. So this is not thyrotoxicosis induced. You can't say for sure because I haven't biopsied. But on the other hand, carbimazole is well known to cause very severe cholestatic hepatitis. So carbimazole is well known to cause that. But on the other hand, thyrotoxicosis is not known to cause this much of cholestasis. Okay.
And then we have another question. If the direct bilirubin fraction is more than 20%, can we take it as direct hyperbilirubinemia, even though the indirect bilirubin is also high?
That there is something like that, but I don't think it is very reliable. There is something like that, but I don't use it clinically. There you just can't give various figures for it, right? So generally, if the direct bilirubin is high, you take it as uh, direct hyperbilirubinemia. There is something in that. That's what the student asked, but I can't give you a good answer for that because it is it's not very well validated that exact percentage of direct bilirubin beyond which to call it whatever. That principle I have heard of it, but I do not know the explanation. No, I don't know that explanation, Natasha. Sorry. Okay, what's the other question?
Is there a place in IV N-acetylcysteine in dengue or other conditions with high AST and ALT?
Tell me again.
Is there a place for IV NAC, N-acetylcysteine, in dengue or other conditions with high AST and ALT?
Right, okay. I will give you the answer. N-acetylcysteine has been shown to be beneficial in patients with acute liver failure. Usually it is used to treat acute liver failure and paracetamol poisoning. So in non-paracetamol poisoning acute liver failure also, there's a good study from US to say that N-acetylcysteine is beneficial in acute liver failure, delaying the survival up to transplant. So if you give N-acetylcysteine to patients with acute liver failure, and acute liver failure should be not due to paracetamol. The benefit in paracetamol-induced acute liver failure, we all know. But if the acute liver failure is not due to paracetamol poisoning, still N-acetylcysteine has intravenous N-acetylcysteine has a place. For that, you have to diagnose acute liver failure. How do you diagnose acute liver failure? There should be encephalopathy. There should be elevated INR of more than 1.5. So if you diagnose acute liver failure in any form, then there is a place for N-acetylcysteine intravenously. Just because your transaminases are elevated, there is no indication for the use of N-acetylcysteine when there is no acute liver failure. So N-acetylcysteine should be reserved for patients with acute liver failure, that is hepatic encephalopathy, any grade, and INR of more than 1.5. So if in a patient with dengue, if the patient is acute liver failure, there is a place, and we have done a study at Ragama. We also think it's not a randomized controlled study, but still we think it is beneficial, and we are using N-acetylcysteine dengue patients who have features of liver failure. Yes.
And then we have a question on what is the AST and ALT levels that we should not start statin?
We should not start statin. Yes.
Yes. So
statin.
Yes, sir. The question is, what is the AST and ALT levels at which we should not start statin?
Right. Okay. So again, a very good question. So when not to start statin, right? Okay. It all depends on the etiology, right? So if the etiology is fatty liver or non-alcoholic steatohepatitis, if you diagnose non-alcoholic steatohepatitis, even if the liver enzymes are elevated, we do start statin. There's no contraindication because at the end of the day, with the treatment of statin, with the correction of lipid abnormality, in addition to whatever the lifestyle modifications, patient's liver enzymes will come down. If the diagnosis is non-alcoholic steatohepatitis, and it is the diagnosis in most of the patients that we treat in our day-to-day practice. So if we can give that license that it is safe to start statin in patients with diagnosed non-alcoholic steatohepatitis, irrespective of the liver enzymes level. So liver enzymes levels, we don't check before starting statins in patients with non-alcoholic steatohepatitis. In addition, statins, now we know that it's going to be one of the most important drugs in cirrhosis. So if we can start statins in cirrhosis, right? What's the issue in starting it in a patient with elevated liver enzymes? The patient is clinically stable. If the patient has no features of acute decompensation, like the bilirubin is normal, the INR is normal, then it may be some kind of a treatment for chronic liver disease. So we should not be stopping or avoid starting statin in these patients, because most of these patients do need a statin, not for the liver, but to prevent the myocardial infarction. So statins are going to prevent myocardial infarction in most of these patients with fatty liver, because the main cause of death in these patients is myocardial infarction, not liver failure. So all these patients with fatty liver, right? Now, the American Diabetic Association says if someone is above 40, if someone is having diabetes, then they should be on a statin. Just because they are diabetics and above 40, they should be on a statin, right? So statins are over-the-counter medicines in some countries. You can go to your pharmacy nearby, you can buy statin without a prescription, right? So statins are much safer than diclofenac sodium and coamoxicillin, right? So if you take the number of prescriptions of statin and patients who have died due to statin, you just can't compare, right? Very few. So I don't think maybe during acute hepatitis you don't start it, like the bilirubin is high, the INR is high, you don't start. But otherwise, we just don't take the transaminase level into consideration before starting statins now. If the transaminases are elevated, if you don't have a diagnosis, then you have to diagnose it. And when you diagnose fatty liver or NASH, then just because the transaminases are elevated, we do not stop initiating statin treatment in these patients. Okay.
Yeah, the final question which we'll take today. COVID-19 pneumonia, we frequently see AST and ALT elevations. Is there any way to differentiate whether it's due to COVID hepatitis or cytokine storm?
No way. It's very difficult now. Say now again, like in dengue, the elevations could be due to direct viral effect, then immunological and cytokines, then finally hypoxemia. Okay, so say direct viral, maybe the pattern may be ALT more than AST. If there's cytokine storm and immunological activation, maybe ferritin is sky high. That happens in dengue. In dengue, ferritin is sky high. By the time they develop this cytokine storm and transaminase elevation. In hypoxemia, then AST should be more than ALT. I don't think anyone has done biopsies to differentiate between these, right? So very interesting question, but I don't have an answer. But I do know that people are studying a lot on those. So fascinating topic, but very unfortunate for the patients. Okay, Natasha, any other?
Yes, any other questions or comments from the audience? Okay. In the absence of any more questions, I'd like to conclude the session for today. I would like to thank Professor Anuradha Dasanayaka once again for the excellent lecture. And also, I'd like to thank our audience for interactively participating in this lecture and joining the lecture today. So I'd like to wish all of you a safe week ahead and good night. Thank you.
Thank you, sir, and coordinator.
Thank you, Natasha. Thank you, all the participants. Really enjoyed it. Thank you very much.